one of the keys that was taught is that you should always combine it with the. So the middle blade is actually very good in terms of coming from a hunching or coming from the side. The epiglottis, having the tongue all the way off to the left, and you get very good views, although it's very narrow. And if you, the tongue has to be all the way on the left of the blade because the surface area is quite small. So you get very good views, but if you try to pass an endotracheal tube, it will block your view. So you're just hoping that it follows the channel that you've created. So what is better is if you have a preloaded bougie, you pass the bougie, you can see the bougie pass through the cords, and then you can immediately railroad an endotracheal tube. It's very useful. Okay. The Bullard scope I was introduced at that time, and this is the prototype of the video laryngoscope channel scopes. So it was very good in terms of difficult airways, in terms of anterior larynx, some unstable C-spines. The problem is it's quite a wide profile, so you need a significant amount of mouth opening to insert it in. And this prototype actually, the view through the camera or view through the eyepiece is not aligned to where the endotracheal tube is going. So you have to actually offset that on the spot. We're taught how to intubate mainly to the mouth, because if you intubate to the mouth, intubate to the nose, as we actually know. And I was only taught to intubate from the top side, not the strain. Hospitalization, bicarbonate, or anti-dialysis. Basically nebulized. And at that time, the Lubricate dose was only 6 milligrams. So starting, sometimes we would dip local anesthetic with a cotton ball and try to cross forceps and put it in a vertical faucet. You can just slide it into the patient's mouth and just sort of hiding down onto the forceps. And when you hold it there for a minute, you take it out and you do the same thing again. This is atomization. This is spraying where you twist down back of the tongue, and then you ask them to inhale, just squirt through those and aspirate. Nerve blocks, which was fossil-pharyngeal, which I think was like dentistry, so I not thinking of the product already right there. The better ones are block, it's just the hyoid bone, and the most important was the transtracheal block with the mass conductions was basically for pediatric pieces, which held down. But for adults, it's tough to gauge the depth of anesthesia for direct laryngoscopy at that time. Too light, the patient's going to gag and go into laryngospasm. You may lose their airway. Too deep, and especially the elderly, they have very little blood pressure. So even despite this, they made airway. We were taught blind nasal intubations. We were taught retrograde intubations as well. And then can't intubate, can't oxygenate scenarios. Basically, you called for help, and you either did a scalpel or a needle cannulation method, or you wait for ENT to come do a surgical tracheostomy. So as a resident, we weren't actually taught surgical airways. This is the doctors that we learned from on TV because it seems so easy. You take something sharp, put it through one of the spaces in the neck, and then you stick some kind of tube in that hole that you created. What we were taught in anesthesia actually was to find the cricothyroid membrane, take your biggest IV, stick it through the cricothyroid membrane, add a 3 cc syringe, a 7 ETT connector, and use an ambu bag to bag through that. Now, this was not formal training. This is sort of OT table training where your mentor was like, oh, this is what happens if you totally lose the airway. There were no formal lectures. There are certainly no workshops, and there's nothing in the literature about this. So in 1996, I went to the University of Western Ontario, London, Ontario, which is southwest of Toronto, to do a neuroanesthesia fellowship in a quaternary hospital, where they specialized in cardiac, neuro, transplant, and actually bariatric surgery.
So the airway assessment was basically the same, but as a fellow, I didn't extensively examine the airway as much. It was just sort of like take a look, open the mouth, and that looks pretty okay. And especially as the patients were moving towards SDA and somebody else was actually seeing the airway the day before. So you only had a few minutes to see the patient before you actually anesthetize them. The induction at that time had radically changed to propofol and rocuronium. So there was less use of neuromuscular blockade monitor. There was actually less topping up of muscle relaxants because remifentanil started to come on board at that time. So my bag valve mask technique was improving because I had to deal with obese patients, and because rocuronium take a little bit longer on onset, and we would hand ventilate a bit better. So my technique started to improve in terms of this situation. The Procio was introduced at this time, but we only used it in day surgery and young, healthy athletes, fairly short procedures, like less than 2 hours, and we never paralyzed the patients. And certainly we weren't using this as a rescue device. The glide scope came into uh, use at that time, and we were using this just as a novelty to see how things were. We were a bit anxious about using this as a rescue device because of the reports of severe laryngeal or airway lacerations that needed surgical repair with this. Most interesting was the residents introduced me to the trach light, which is a optical stylet sort of that you intubate blindly by transillumination. Great for anterior larynx, great for difficult intubations and limited mouth opening. And bloods and secretions don't bother you. The problems were that you're not quite sure about airway injury, and you certainly shouldn't do this for airway tumors. Okay, so this is just a quick video of the trach light where you anesthetize the patient, and you just insert it into the mouth.
Sideways first, out the middle.
And you just follow the bright light as the bright light goes down
It up the jaw
upwards and into the fascia.
underneath.
So it should be bright light,
Turn off the
bright
knob.
light, bright light all the way until you go past the thyroid prominence. Okay? If
Turn it
it's
off,
bright,
turn it
bright,
off.
dull, then you've gone into the esophagus. Okay? And then once you're in, you just railroad the endotracheal tube. Okay? At that time, I was introduced to the optical stylets, the Bonfils and the Chicani. Very good for difficult intubations, but I was just learning how to use this. You should use it as a retromolar approach. You only need one hand actually to guide it because it's stiff. And the tube is right there, so there's no railroading difficulties. Front of neck access at that time was the same, needle or surgical by ENT. So I had less head and neck work here, but I was treating obese patients, but the Caucasians seemed to be easy to intubate these patients, and we did rapid sequence, so nothing there. So this year was basically spent practicing on using the Procio, learning the glide scope, the trach light, and the Bonfils on basically normal airways. So in 1998, I moved to Singapore, and I found a huge difference between the Asian and the Caucasian airway. The Asians tend to have more anterior larynx. They have a much more sensitive airway, a much more sensitive gag reflex. And the other problem is they're more sensitive to narcotics. I could give 5 mics per kilo of fentanyl to a Canadian and he wouldn't budge. But I give 1 mic per kilo of fentanyl to a young Asian girl and she'll start coughing violently potentially. It's quite disturbing for me. There had been less obesity at that time. They tend to be easier to ventilate. So I had real trouble emerging these patients smoothly, even on laryngeal mask. And there are significant implications for awake intubations in these patients. So in Singapore, the assessment was shifted to the pre-anesthetic clinic. They were done by junior doctors. So when we got to the patients, we had 5 minutes to establish whether it was good or not and a plan. Bag valve mask was intensely trained because we were intubating with atracurium. So you needed 2.5 to 3 minutes of good bag valve mask techniques to maintain oxygenation and ventilation before you can intubate. So other than standard, I was introduced to the McCoy blade, which has this flex tip at the end for difficult intubations. Difficult airways were basically the same technique. Okay. The interesting thing was as soon as I arrived in Singapore, they paired me with a young head and neck surgeon who was very ambitious. And every Friday, he would have a very long list with difficult airways. So my plan was and so by attrition, you had to be able to secure these airways. Otherwise, it's local trach. And what's the point of being an airway specialist? So this is where you develop airway specialists. And you know that the population here and in Singapore, fairly high significant incidence of NPC with radiotherapy. And the culture is that they tend to let their cancers brew on a long time. So your airway complications or your airway problems are actually quite high. The other thing was, so I'd be working the latest on a Friday, basically alone, the farthest away from the recovery room. So you had to really develop your airway skills, not only for intubation, but for extubation and planning. So we had to deal with a lot of these types of airways and things. And at the same time, there was a huge explosion of airway equipment. There's multiple generations of airway devices. There were the iGel, I'm sure you're going to be familiar with, has no cuff. The AMBU has been designed so that it's disposable and the internal diameter is actually quite wide so you can intubate through. The video laryngoscopes, the glide scope standard, the CMAC came around with the normal Macintosh curvature, which is good for teaching, but less good in terms of anterior larynx. And then the McGrath came out, which has the smallest profile in terms of limited mouth opening. So that was the great thing about the McGrath and its portability. There were channel instruments like the Pentax scope, which actually got rid of the problem of lining up the camera and the endotracheal tube because they have a targeting system that you just line up the target and that's where the endotracheal tube will go. Okay, and there's multiple optical stylets that came onto the market. So this is my favorite intubating instrument for difficult airways. It's the Bonfils. It's preloaded onto an endotracheal tube. And you just basically put it in the mouth and you just follow the tunnel that you've created by your draw thrust. And you can get very good views of the airway. And then you just slide the tube in. Okay. Despite all these airway instruments, okay, we still have can't intubate, can't oxygenate scenarios, about 1 in 10,000, probably even higher rates because it's probably underreported. And our A&E colleagues have it even worse. It's like 1 to 5% of their cases are can't intubate, can't oxygenate scenarios. Okay, so in 2011, the NAP4 came out by Tim Cook and the DAS Society. And they went through and they found that ePhona or can't intubate, can't oxygenate scenarios were quite similar in terms of 1 in 12,000. And they found that there was poor airway assessment, poor aspiration risk assessment, and poor planning. And the ones that you're running into trouble are obese patients, which doubled the risk, and head and neck cases, which formed 40% of those major airway complications. There were inconsistent algorithms. People weren't following them. There's inconsistent equipment and its availability. And there's inconsistent skill levels and training. And this is particularly for front of neck access. So you know that there's tons of algorithms on the market or from different countries. They all end in basically can't intubate, can't oxygenate scenarios, and front and neck access. So then the problem is, do you pick up the needle or do you pick up a scalpel? So for me, in 2014, there was a conference, the ANSCA conference in Singapore, and there was a debate between Paul Baker from New Zealand versus an Australian. Paul Baker was very convincing in terms of scalpel techniques, in terms of puncture the scalpel through the cricothyroid membrane, twist, put a bougie in, and then roll a size 6 endotracheal tube. Easy. Put the cuff up, you've protected the airway, you can oxygenate and ventilate with an ambu or your ventilator. And you don't have to worry about needle moving, kinking. You don't have to worry about an oxygenation high pressure system through that needle cannula set. So, and to back this up, the DAS in 2015 had their airway guideline update where they said you should only use scalpel. The scalpel technique seems to work, especially in the ED and the out of hospital setting, and in workshops and anatomy labs. Okay, the needle cannula set, high failure rate, 65% first pass failure rates, and the oxygenation method, which is usually high pressure, sort of manujet, high pressure jet ventilation, was incredibly dangerous and high morbidity and high mortality rates. So that and train and retrain for scalpel techniques. Okay. So the Royal Perth Hospital, what happened was in 2013, I met this physician anesthetist from the Royal Perth Hospital, Dr. Andy Hurd, and he was talking about his wet lab. And then he was actually the one who was supposed to speak at that conference about scalpel versus needle, but he couldn't make it. So I invited him for an airway conference in 2017, and he brought videos about his wet lab, and it was flabbergasting, such that I actually went down to his lab in 2019. Now, what his group has done is he takes a live sheep, he anesthetizes the sheep, fully lines the sheep, fully monitors the sheep. Then he pulls out the endotracheal tube, lets the sheep desaturate to 80%, then introduces a candidate to rescue the sheep. Okay, the sheep is already prepared perfectly in terms of neck access. Okay, so they tested various equipment, various oxygenation techniques, scalpel versus needle, all the different types of equipment. They went through this over 10,000 times, anywhere from medical students to senior consultants from A&E, anesthesia, ENT, intensive care. What they found is if you take a 14 gauge Insight catheter and a rapid O2 set for oxygenation, that was the fastest, most reliable way to reoxygenate the sheep. Okay? We're not talking about controlled ventilation area, but just to get the saturations up was the fastest, most reliable way, especially if you cannot palpate the anatomy. Okay. They also found out that if you fail needle cannulation, you can go into scalpel bougie. But if you start scalpel bougie, you cannot fall back to needle cannulation. Okay. So if you can get the saturations up, then you can breathe a sigh of relief. You can think more clearly, and then you can plan for a more secure airway. So they came up with this whole algorithm for front of neck access. Okay. When I went to the lab and I did this, it was the most hair-raising thing that I've ever done. I mean, even though it's a sheep, you're surrounded by your peers. The monitors are screaming at you, and it's only you that's going to be rescuing the sheep. Okay. So at this point in time, I've sort of I think I've settled my stewardship or being the steward. Okay. So how to go from the steward to the stewardship? Well, as you saw, you have to express active interest. You have to show skill. You have to have the staff and leadership acknowledge what you're doing or what your skill is. And then you have to be designated the responsibilities from them, assemble a team, and then self-expansion of your role, meaning you have to go for it. You can't be, bashful about these things. Okay. So from the department point of view, there's interactions with the distributors and vendors of the airway equipment. So they hopefully come and introduce you to airway equipment, and then you come and you trial them clinically and see how they are. And they're actually very good contacts in terms of loaning you equipment for workshops and things like that. In 2004, my seniors had developed the CATS, which is a chest tube and airway training for the juniors, because we had juniors coming into our department every 6 months. So when they asked me to take over the workshop in 26, 2006, I changed to the FAT workshop because I think my residents or my MOs needed to learn about airway and central line and art lines and invasive monitoring. So we did that every 6 months. And then we added in a advanced airway uh, fiber optic training. Then in 2017, we did in-house training every 6 months. And then in 2019, one of my colleagues added in crisis simulation. What happened? Okay, sorry, crisis simulation in the operating theater with an empty operating theater. So all the faculty was volunteers and we were training the juniors, okay? And then finally it was annual capital budget where we were asked to change or replace broken instruments or put up budget for new airway instruments, okay? Teaching was every 6 months. For the 6 month training, we did individual and team training. We trained in front of neck access. We trained in low skill fiber optic intubation, which is intubating through the intubating through a supraglottic device. We we taught jet ventilation, topicalization, and high fidelity emergency airway scenarios. We are now developing both post-thyroidectomy airway crisis management, similar to the DAS. Okay. So along with that is innovation. We have gone out and we've gone 3D printing of our airways, so the laryngeal access, and we make our own front of neck access models. We use styrofoam heads and we carve this out and we add in our own models so that we can train for percutaneous tracheostomies. And we alter the anatomy sort of so that we either use corrugated tube to mimic the trachea or we use pig tracheas. And they can be in either standard or alternate models. Okay, up top is 3D printed airways, and on the right are gels that we made for normal and difficult front of neck access models. Okay, so in the interdepartmental hospital, we have a really close relationship with head, neck, and ENT. So there, obviously there must be co-management of difficult airways patients, and there's airway lectures between the two of us groups. Most important is my ENT group. They have a fortnight workshop where they do surgical head and neck stuff on cadavers. So they get about 20 to 30 cadavers every year for this fortnight. So I go up to my colleagues in ENT and I say, hey, can I have your leftovers? So I arrange my workshop a few days or a week after their workshop, and I use their cadavers to do airway management on either upper airway or the head and neck. It's fantastic. Okay. For my emergency department colleagues at my hospital, it's a bit contentious because the head of the airway department over there, we don't have a good relationship. Hopefully that will change when they change over. But they send over their ED residents to anesthesia for training every month or in 1 month blocks. Respiratory med is, again, cooperations and collaborations when you're doing rigid bronchoscopy and stenting. And then our nursing colleagues, we need to train them. Not only we teach them airway management for their graduate program, but we have to train our AU nurses so that we can function as a team so that they know actually what we're saying and what we need, and they can anticipate what we actually need in the situations. We opened up our FAC workshop to the other departments. we formed up or we advised on our code blue teams. So when there's arrests and airway management, we teach them and we package the resusc equipment. And we also have our own pre-packed backpacks for our airway teams from anesthesia to rescue airways in remote locations. Okay. We also are involved with the national group purchasing. So all the public hospitals, actually, their airway specialists and equipment specialists gather every year to see if they can come up with consistent, like, let's just buy these types of endotracheal tubes. Let's buy these types of supraglottic devices or adjuncts, these types of video laryngoscopes for the nation. Okay. The last one is the post-COVID hospital purchasing. So pre-COVID, I was working with the McGrath group, and they would loan me their McGraths um, to use, and they seem to forget that they keep loaning it. So I was using 1, 2, 3 for the department for up to 6 months and we would buy the consumables when it changed over to the consumable. So we just bought the consumable blades for the scope. And then after about 7 years, uh, we managed to gather 17 McGrath handles. And we made a deal with them that we would purchase 1,000 blades a year for 3 years. And they would throw in the handles for free. So when COVID hit, we had 17 handles, and we didn't need them. So all the other departments were asking us if they could borrow our McGraths, which was, isolation wards, the ED, and the other intensive care units. So we gladly loaned out the rest of them. So post-COVID, the hospital realized that, hey, we should actually purchase a whole amount of handles. So I said, that's great. Uh, Come and advise. I can advise you in terms of what to do in terms of negotiation. But they never came to me for negotiation. So a month later, they come back and said, we bought 105 handles for the hospital. We can give you 80. And I said, I don't need 80 handles. I only need 30. Actually, the 17 that I have now is enough. And they said, oh, okay. Can I ask, why are the blades so more expensive? I said, I didn't say you idiots, but of course they're going to throw in, when they throw in that many handles free, they offset it by jacking up the prices of your consumables. And then I asked them, did you ask for free batteries? And they said, huh? I said, the batteries are inbuilt death. They are proprietary. They only last for a certain amount of time, and they're very expensive. They're $80 Sing each. So they said, oh, didn't know that. I said, yeah, you didn't ask me. So you have to be quite bashful. I should have been more forceful in terms of advisement. Okay, so research, this is mainly personally driven, and it's mainly case reports and retrospective studies. It's very difficult for us to do RCTs. We don't have we didn't have the infrastructure at that time. What we did was some clever individuals, my colleagues, would develop swab techniques in a booth safe for the swabber for COVID. They also developed the airway box for intubation of COVID patients. My biggest disappointment was this scope. It's a AI-driven robotic intubating scope developed by Vladimir Nadzetsky from Stanford. And he called me up and said, hey, can we do the first human trials in Singapore? And I said, I cannot. It won't pass through our human authority boards in the time frame that you've given. So we had to pass up on this. But that's what is available, if you have a firm infrastructure. Okay, residency or anesthesia residents come through ENT or anesthesia airway, about 1 month block in R2 and R4. Uh, and then I send out my airway enthusiasts as associate consultants to various areas to do airway fellowships. The best program, I think, is probably Halifax, Orlando Hung in Canada. It's not for, basically, they're trained in airway already. What you need to develop is actually um, out of hospital stuff in terms of Orlando and Halifax. He sends his fellows all across the continent for workshops. He has outreach programs in Africa. So the so it's actually the outside stuff and the opportunities for papers in terms of research and stuff like that that is best for fellowship. Because I mean, we do have training, but we don't have a fellowship program in SGH in Singapore because there's not enough cases, and our cases actually are sort of geared for our residents. So if you have residents and you have fellows, there's a lot of infighting in terms of the cases that need to be done. So it's best to build up your out of hospital, out of OT kind of programs that will attract your fellows or should be sent for your fellows. Okay, then so bottom right is Orlando Hung. I saw him last month, and he's teaching my daughter how to use the new prototype trach light, which will be coming out next year. Okay, so then there's constant upgrading and networking. Okay, so if you noticed in my talk, I've met Richard Levitan, who's the designer or inventor of the laryngeal shake. He's an ED physician in America. Uh, this led to basically at that conference, ED physicians came down from Singapore and they heard me talk and they invited me up to KL every year now for CASTER, which is the ED airway management course. Um, and then I met up with Andy Hurd, who is the head of the Royal Perth Hospital, who has that fabulous sheep wet lab. And then later on, I networked to found the Airway SIG, the special interest group in Singapore, where basically the airway heads from all the public hospitals came together to form a group. And at the same time, we decided we would gather together and we would have a national workshop so that we wouldn't compete for uh, residents. We wouldn't compete with the vendors for sponsorship and equipment, and there wouldn't be faculty fatigue because the same faculty would be going to different hospitals. At the same time, so special interest group from the national platform and the national airway program in Singapore that we developed, and it's being the 10th annual one will be in 1 year's time. So the concept was basically to amalgamate all the airway experts in the various public hospitals to come together. And for me, the inaugural one, I actually invited ENT, ED, respiratory medicine to help us run the workshop as well, because airway is just not anesthesia. There are things that we can learn from our A&E colleagues. There are things that we can learn from our ENT colleagues. There are things that we can learn from our respiratory med colleagues. So there's a pooling of faculty, equipment, finances, and support. And we did a number of simulations, advanced airway measurements, and things like that. Okay, so internationally, as you know, there's international multi-center trials that we've been involved in, international speaking and workshop engagements. As I told you, up in KL, I go every year for the CASTER. I went down and I send my fellows down to Perth for the front of neck access at the sheep wet lab. We actually held the pre-Congress workshop, airway workshop for the World Congress 2 years ago. That was a bit contentious because we didn't really get along with WFSA, and they basically cut all the funding from this workshop that we present. We had to find our own funding. They stole basically all the local airway equipment, but luckily my relationship with the vendors in Singapore, they hid some of the airway equipment, so we actually could run the workshop, which I thought was quite. I thought we were going to lose money, but we actually made money for the group. And then at the same time, I was supposed to co-organize the RAM at that time, but I was too busy with the WCA. So I just helped out in terms of talking and post workshop at RAM, some advice in terms of it. But again, problematic was I think the DSA, the UK boys have sort of co-opted because this year the scientific chair for the regional anesthesia meeting for Southeast Asia is Imran, who's the head of DAS or the ex-head of the UK Foundation. So there are a lot of politics that you have to go through during your stewardships. And then my senior management wants us to farm out the NAPs to various Southeast Asia countries. Okay? I'm sorry. How much time do I have? 10 minutes? Okay. So that's the stewardship part. So I just want to talk about what's happening now. What have I done to refine myself? So my assessment is actually much more extensive now, especially if you're looking at imaging. And the other thing is doing a nasal scope preoperatively or having your ENT colleague do a nasal scope to check out the airway beforehand. The best bedside test these days is the upper lip test, where if you can bring up your upper lip to the vermilion border, that's okay. But the more teeth you show, the worse your airway is going to be. Okay. My esteemed colleague Sharon will talk about ultrasound guided, but you should preoperatively, especially if it's a difficult airway or a borderline airway, is find the cricothyroid membrane and mark it out. Okay, gastric ultrasound to see about full stomach risk and aspiration risk, and using lung ultrasound or airway ultrasound to confirm tube placement, which may be a bit delayed, but also looking for a pneumothorax. Okay. Like I won't go through the action plan, but pick a plan, stick to the plan, okay, and inform people about the plan. Okay. So if it's a normal airway, not to worry. Okay. If it's a difficult airway, most likely you should do a wake. If it's a borderline airway, plan, pre-oxygenate. I typically use general anesthetic with rocuronium with sugammadex standby, but don't think that sugammadex will rescue you 100% of the time, because it may not. Because if it's a difficult airway and you mash up and the airway, if you reverse with sugammadex, it may have screwed up the airway so much that even if they get spontaneous ventilation, they may not be able to breathe to the obstruction that you've created. Okay? Okay, and so basically, you don't need to confirm ventilation, bag valve mask ventilation before you give the muscle relaxant. You're just wasting time. If you think you depend on ventilation, bag valve mask ventilation before as a problem, then you should have kept the patient awake. All right. The whole point is to get the muscle relaxant on board so that it improves your ability to bag valve mask, improves the ability to put a supraglottic device, improves the ability to intubate, and it should be on board if you have to move on to front of neck access. Okay. I use less mask inductions with SIVO and have ENT standby. Okay. I usually go by the Vortex Australian method. It just means that you have 3 attempts at every corner in any order, as long as you change things up at each event, right? Because it's not like I have DL, I have my video laryngoscope, and I have another different video laryngoscope, so I can do bang, bang, bang. It's like, okay, I'll do a VL, doesn't work. I have my supraglottic device, I put that one in, doesn't work. Then I need to change things up because your AO nurse is running for the other equipment that you want, okay? Have an airway cart, stock it appropriately, label it appropriately in a logical method, okay? have your chart readily available or visible so that you can assign roles and people remember what the roles are. Okay. In every operating theater at my hospital, we have a needle cannulation kit. Okay. Inside catheters, syringe, saline, and a rapid O2 set, which I'll talk about in front of neck access. Uh, this delivers oxygenation. You just put 15 liters through, you occlude the T-piece to this is commercially available called the Rapid O2. So this lure locks to your cannula. This goes to your oxygen source, and this is a T-piece for your thumb that you occlude for. So this is 15 liters per minute, which is 250 cc's per second. You occlude this for 4 seconds, it delivers a liter of oxygen to the patient, and you follow the saturations, okay? These are quite expensive, $50 Sing. If you don't want, you can make your own. This is a regular oxygen tubing. This is a T-piece that you can find anywhere. And this is a lure lock tubing. This is actually cardio bypass tubing, but any tubing will do as long as you can lure lock it to your 14 gauge inside catheter. Okay, and then we have our scalpel bougie set. Bougie, size 6 ETT, 10 blade scalpel. Okay, uh, if you have access to ECMO, that's a nice standby. I think I don't have time to talk about preparation and flow oxygenation. Think about physiological difficult airways, okay? You should have a separate person controlling the hemodynamics, fluid resuscitation, inotropes, vasopressors, while somebody else is handling the airway, okay? We found that the bag valve mask technique, the V approach on the far right seems to be better than the C approach for reducing aerosolization of viral particles. We standardly have 2 types of laryngeal masks at my hospital. Okay, the ProSeal, which is reusable and it molds nicely to the airway. So non-neutral supine patients, I like to use the ProSeal. Then we have the AMBU, which is a fixed, preformed, disposable unit. We like this because the internal diameter is big enough that you can do intubation through. There is the video laryngeal mask, which it's quite big and bulky. I actually prefer to do the low skill through the AMBU as opposed to this. We usually stock basically the McGrath because of its low profile and its ability to go anywhere. It's quite portable. The video laryngoscope technique, basically, you want a minimalistic view, okay? You actually don't want a grade 1 view, to be honest. Because if you have a grade 1 view, that means the angle must match your endotracheal tube must match that angle. So if you haven't matched that angle very well, it's going to go to the esophagus. So if you actually lessen the view, then your endotracheal tube has to go less anterior, basically. The other thing is you don't want a very close-up view of the airway, because if you're very close up to the airway, that means your endotracheal tube has to go the longest distance blindly to get into the camera view to intubate, right? And that blind insertion of your endotracheal tube can cause a lot of damage, okay? So if you're farther back, then the distance from the endotracheal tube to the camera is shorter, and you have a longer distance to maneuver your endotracheal tube to the airway, okay? Metal stylets are very nice to put in for video laryngoscopy, but you should actually match it to the angle. I actually like this one that allows you to actually flex the tip of the Fuji. For fiber optics, it's nice to actually put a epidural catheter down through the fiber optic scope. So actually, when you get close to the airway, you can snake out the epidural catheter and you can actually inject local anesthetic directly where you want it. And then you can actually push the epidural catheter through the cords, and it's almost like a guide wire for your fiber optic scope. Okay. When you're scoping from the front, there are differences in orientation. Okay, so when you go up through the nose, it's fine. Left is left, right is right. But when you go behind the sort of the oral pharynx, it's reverse. Left becomes right, right becomes left. So the easiest thing for me to say is when your thumb is up when your thumb is up superior, your scope is going down, and your left is right and your right is left. When your thumb becomes neutral or down in the flex position, then the orientation is correct. Right is right, left is left. Okay. I think I'll skip that. Tubes, sedation. Something that's interesting for sedation would be what we do is we take an oral airway, put a size 6 ETT through the oral airway, and put the bottom end of a nebulizer to connect this to oxygen source. So local anesthetic for topicalization is actually 9 milligrams per kilo, right? You can do 20 to 30 sprays of 10% lignocaine to the tongue, then lubricate this contraption and get the patient to put this in his mouth and insert the oral airway all the way in. And you will nebulize directly the airway. It's a fantastic technique that was taught to me by one of my colleagues in Singapore. So once you topicalize, you can basically do anything in terms of topicalize well. You can intubate with video laryngoscope. This is my colleague that was topicalized and is now being intubated awake. And I chastise him because there's no IV, there's no glycopyrrolate. And basically what he learned was the posterior tongue is the most uncomfortable. Secretions were a problem, so antiseptic is a good idea. Don't aim for a perfect view. The more you try to aim for a perfect view, the more uncomfortable the patient will be, and there's no real gain. Am I out of time? Yes? Okay. I highly recommend you look up DMB heard airway. This is everything they want to know about front of neck access in terms of needle cannulation and scalpel bougie techniques from this wet lab, okay? So other than short of going to the wet lab, this is quite useful. And I know this is against the DAS and their difficult airway guidelines, but we as anesthetists like options. And two, we don't, sorry, our patients are different from A&E patients. They're different from the out-of-hospital patients, okay? We deal with usually the most difficult airways, and we feel the most responsible. And we are kind of a bit scalpel phobic, and we're more comfortable with needles, okay? So I'm not saying you don't need to know. You do need to know how the scalpel technique is, but I believe that if a needle technique is actually preferential and should be done first, but you need to stock your locations with this equipment, okay? And don't forget about disposition of the patient, okay? Thanks.
Thank you very much, Dr. Ted Wong, for the insightful presentation on the critical systems and clinical leadership required for effective airway stewardship. So moving from institutional system to bedside precision, our next speaker will focus on utilizing technology to predict the unpredictable. Please welcome Dr. Muhammad Shafiq bin Shokri, an anesthesiologist anesthesiology specialist currently serving at Hospital Tengku Ampuan Rahimah in Klang. Dr. Shafiq is a dedicated and accomplished medical professional with over 14 years of experience in the field of anesthesiology, encompassing comprehensive perioperative care, intensive care, and pain management. He completed his Master of Medicine in Anesthesiology of University Putra Malaysia in 2023. Highly skilled in regional anesthesia and ultrasound guided procedures, Dr. Shafiq places a strong focus on clinical outcomes and medical team training. Today, he will be leveraging his expertise in ultrasound technology to discuss a vital component of advanced airway assessment. Please put your hands together for Dr. Muhammad Shafiq bin Shokri as he presents on difficult airway evaluation with sonography.
Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all esteemed guests, ladies and gentlemen. First, I would like to thank the Madam Chairperson for the kind introduction. Next, I would like to thank the organizing committee for giving me the opportunity to talk on this hall. So, as anesthesiologists, we handle airway management every day. That's our bread and butter. We spend years and years in perfecting and refine our skill in performing laryngoscopy, video laryngoscopy, LMA insertion, fiber optic intubation, and even EPONA. And before we even start to induce and intubate our patient, there is always that one question that lingers in our mind. Does this patient in front of me going to be difficult? The question seems to be easy because we have done our due diligence, have we done our pre-op assessment, but for some reason the answer is not so straightforward. So today, in order for us to help managing this scenario, I would like to introduce ultrasound to help us managing our patient's airway. So today I'm going to introduce the DES protocol, which is a difficult airway evaluation with sonography. So I hope by the end of today's talk, you can see that ultrasound is not only act as a gadget in our management, but it can be as a second pair of hands. So we'll go through 5 things. Number 1, why do we even need ultrasound in airway management? Is there any role of ultrasound in this? Second, let's understand what are we actually looking at. So we go through the surface anatomy and the most importantly, the sonor anatomy of the upper airway. Third, I'll introduce the difficult airway assessment using ultrasound. Fourth, we'll have a look at the function of ultrasound other than predicting airways. So other than predicting airways, there's a lot more. Last, I'll try to summarize the practical points that you can bring to your practice. How many of you have encountered this whenever you do pre-op assessment? So let's say in front of you is an adult patient. So while doing your pre-op airway assessment, okay, let's say this patient have a Malapati 2, good neck extension, thyromental distance is acceptable, then you assume this patient is going to be easy. So you proceed this patient to be an easy airway, give all the drugs, and then upon laryngoscope, bam, it is a chromatography 3 or 4, or if you use your video laryngoscope, it's a pogo of 50% or even less. It happened to us a lot of times. I know I have this fair share of this kind of experience. So why is this keep on happening despite we've done our due diligence of airway assessments? Number 1, airway management is our bread and butter. We are the expert in this. But despite being the most expert in this in the field, yet difficult airway keep on surprising us. Evidence from an emergency department showed that around 12% of intubation developed complication. For example, hypoxia, esophageal or endobrachial intubation, or worse, cardiac arrest. And more importantly, majority of our difficult intubation and mask ventilation are unanticipated. That means our current bedside assessment still misses many patients. This article was published in 2014 and is one of the largest Danish studies that look at the accuracy of anesthetic prediction of difficult airway in almost 190,000 patients. And if you can see here, the most striking findings that was uncovered was that more than 90% of difficult intubation and mask ventilation were unanticipated. To top it off, when an airway was expected to be difficult, for some reason, it turns out to be normal. Most of the time, it's 80% of the time. So why does this happen? It's because our current bedsides simply are not sensitive enough. So this statement has been confirmed and supported by this systematic review from Cochrane, which is looked at more than 133 studies involving 840,000 patients. So this review evaluates and look at the accuracy of our current physical airway assessments in detecting difficult airways in normal adults. So all the typical physical examination that we usually do, for example, Mallampati scoring, thyromental distance, Wilson score, and upper lip bite test. So what did they find out? So they all have one common weakness, which are they tend to miss the difficult airway. Even though the test of this physical examination have a good specificity of around 80 to 90%, however, their sensitivity is really poor, 20 to 40% only. So in other words, our current physical airway examination are good at reassuring us when an airway is easy. However, it is much less reliable at identifying patients who are going to be really difficult. So that explains why our difficult airways continues to surprise us. And I bet all of you hate this kind of surprises, especially in our patient's airway. We don't like surprises. So perhaps maybe our current physical airway examination have come to its limit, what it can tell us. So why ultrasound? There is one, ultrasound becomes attractive because of one fundamental thing. Because with ultrasound, you can see what lies beneath the skin. So our current, unlike physical examination, whereby you only look at the exterior surface of the patient, ultrasound can look beyond it. So instead of just estimating anatomy, we are now can measure the anatomy. So instead of just estimating or gauging the tissue thickness, we can actually measure the tissue thickness. Instead of assuming or gauging the neck mobility, we can actually quantify the neck mobility. Apart from that, we all know that ultrasound is easy to perform, which is a good thing. It's readily available and mobile and readily accessible. I'm sure over here, ultrasounds are readily available in every OT. It is non-invasive, easy to learn, reproduce, and easy to teach. But like any other ultrasound application, it is user dependent, which means we need lots and lots of hands-on practice in order to reduce or eliminate this dependency. So before we even scan, let us have a look at the surface anatomy of our upper airway. We all know that these are the typical landmarks that we are going to have. Number one is the hyoid bone, top, followed by the thyroid cartilage, cricoid cartilage, and tracheal rings. Surface anatomy is one thing, but palpation is second thing. If you have a thin neck, like most of you have, so most probably you can feel all this structure. but I don't know about you, I pretty much unable to feel my own cricoid cartilage. So this diagram of the sagittal view of the upper airway. So if you can see here, the menta of the mandible is connected to the to hyoid bone by a genio and myloid hyoid muscle, and below it is our tongue. And then we go down from hyoid bone, that is connected to the thyroid cartilage by the thyroid hyoid membrane, and even below it is the cricoid thyroid membrane connected to cricoid cartilage. This diagram summarizes all the 5 main focus airway that will help us in airway management. So starting from the top, number 1, which is the suprahyoid view, which will help us in mainly to do oral assessment. Next one is the thyroid view, whereby it can help us in identify the epiglottis. So by identifying the epiglottis, we can measure the distance from skin to epiglottis. Moving lower is the thyroid view, whereby you can see your vocal cords and then you can evaluate the function. While the cricothyroid view helps us to identify cricothyroid membrane, which is really helpful in E-fauna situation. Finally, you can help confirm or identify your correct placement of ETT in the endotracheal at the suprathyroid view, suprasternal view. So together, these 5 focused ultrasound view help us in airway management from pre-intubation up until ETT confirmation and E-fauna situation. But for today's talk, we'll focus on the first 2, which is the suprahyoid and thyroid view. This is probably one of my favorite ultrasound view, because by placing a curvilinear probe in a sagittal orientation and place the probe just below the chin. So from here on, you will see the mandible and the hyoid showed by the hypoechoic structure, because in the ultrasound, if you shown the ultrasound on the bone, it's unable to reflect any wave, so it will look like black in color. So from there on, you can measure the distance from your hyoid and mandible, which is your hyomental distance. And then the below structure, you can see this is your tongue, and from there you can measure the tongue thickness. Think about what happens during laryngoscopy. We need enough submandibular space in order for us to displace the tongue. If the hyomental distance is limited, laryngoscopy will be difficult, because it will be difficult to obtain that a single side of line from the to the vocal cord and epiglottis. So among all ultrasound measurement studies, hyomental distance consistently performs well. A recent meta-analysis have shown that it may be one of the strongest predictors of difficult laryngoscopy. A shorter hyomental distance reflects a reduced mandibular space, hence it is less space available for tongue displacement during laryngoscopy. The next measurement is actually quite interesting, because a single static anatomy gives us one story, but a dynamic anatomy measurement gives us a second or another story. So in this view, we compare the hyomental distance in 3 positions. One, the hyomental distance in neutral position. Next is the hyomental distance in REM position. And the last one is the hyomental distance in maximally next extension. So by comparing this measurement, you will get hyomental distance ratio. So there are HMDR1 and HMDR2. So your HMDR1, which is your ratio of your hyomental distance in REM position over hyomental distance in neutral, while the HMDR2 is the ratio of hyomental distance in maximally next extended over neutral position. We know that a lower HMDR values means a more limited neck extension. So in a way, HMDR is a surrogate or indirectly measure the degree of neck extension. So if you have a poor neck extension, means that it will be more difficult to align this airway axis. So hence, your patient going to be difficult during the laryngoscopy. So this one is probably the easiest to understand. If you have large tongue, so it will occupy your oral space more, so less room in the oral cavity, it will be overcrowded. So it become more difficult for you to insert the blade and even lift up the tongue. Previously, when we do pre-op assessment, when we see patient with a larger tongue, we just mentioned in our GA form that this patient has large tongue. But how large is large? There's no numbers, there's no value in it. But nowadays, with the help of ultrasound, you can actually measure it. And we know that if you have a tongue thickness of more than 6.1, you are likely to have difficult intubation. So now let's move slightly lower to the thyroid view, where we can evaluate the localization of epiglottis. So the second important window is the thyroid view. Using a linear probe ultrasound in the transverse orientation, we could visualize this diagram. You can see there, the two stars is the strap muscles. There. So the two stars there are our strap muscles. And then there is structure below it in hypoechoic structure, which is your epiglottis. And from there on, we can measure the distance from the epiglottis to skin, giving you the distance of skin to epiglottis, or in other words, it's the DSE. So to help you to memorize this diagram, imagine the two stars is the eyes of a person, and epiglottis is the mouth of a person, giving you this picture. So if there is one ultrasound view that I want you to remember, is this one. It's a DSE. It is essentially reflects the amount of anterior surface tissue overlaying your airway. It represents the amount of work your laryngoscope has to work through. The thicker the space, the harder it will be. It has the more supporting data from multiple studies across multiple different population, and it has been shown that DSE has one of the strongest association with difficult intubation. Patient with a thicker pre-epiglottic soft tissue, or if patient have a DSE of more than 2.54, are more likely to be difficult. This article, which is a narrative and comprehensive review by Lin, was published in 2023, and it reviewed the current evidences from systematic RCT and meta-analysis regarding the role of focus in airway management. So after review of the available evidences, they ask a simple question. Instead of measuring everything regarding airway ultrasound, because other than the parameters I've mentioned, there are many other parameters that can be yielded from airway ultrasound. So instead of measure everything under the sun, why don't we just standardize it? Why don't we measure only only ultrasound view that has the most supporting data? So, and that becomes DES. So they standardize the measurement with only the strongest evidence. In DES protocol, it only involves two views, which are the suprahyoid and the thyroid view. And then from these two views alone, you can get 5 parameters, which are the distance of skin to epiglottis, DSE, and then from there you can get the hyomental distance, and then you can get your HMDR1 and 2, and also tongue thickness. As I mentioned earlier, DES protocol only requires 2 views, which is the suprahyoid and the thyroid view. The beauty of the DES protocol is simplicity, because from one protocol, it requires only 2 sonoanatomic view, 3 steps. So step number 1, get the thyroid view. Identify the epiglottis, and measure the distance from skin to epiglottis. Write down the number. Step number 2, get the super high view and measure the higher mental distance in 3 position. Measure the higher mental distance in neutral position, in REM position, and in maximally neck extended. And from there on, you calculate the HMDR value, the ratio. So HMDR1 is the ratio of HMD in REM divided with neutral. HMDR2 is the high mental distance in maximally neck extended divided with neutral position. Write down these 2 numbers. Last step is get the super high view, measure the tongue thickness. That's all. 1 protocol, 2 ultrasound views. You will only involve 3 simple steps. From there, you can get 5 measurements. So for by any chance, if the value that you've already measured earlier, for example, if your patient's DSC is greater than 2.54 cm, if the higher mental distance is less than 5.29 cm, if your patient's tongue thickness is more than 6.1 cm, or if the higher mental distance ratio are below or less than the values given over there, so your patients are likely to be difficult in terms of intubation. So if you have this situation, if you counter this, make sure you prepare all the necessary, prepare all your airway gadgets and adjust, have backup plans readily available even prior to induce or intubate this patient. But ultrasound of the upper airway doesn't stop here. It not just predict airways for us, it does a lot of things. Next, we explore the thyroid view, where we could assess the vocal cord function. So from thyroid view, we could visualize the thyroid cartilage. So by using a linear probe ultrasound in a transverse orientation, you can see this large hyperechoic inverted V shape, which is the thyroid cartilage. And then once you visualize this with a slight angulation and tilt of the probe, you can see the vocal cord shown as these small 2 stars over there. And then upon seeing these 2 structures, you can ask your patient to phonate, to make any sounds, and you can see your vocal cords vibrate, move bilaterally. If the patient has a normal vocal cord, for some reason, if only one or both of your vocal cords doesn't move, so likely your patient has vocal cord paresis and paralysis. So maybe you need to consult with your ENT colleagues. Next, we move on to one of the most critical view in can't intubate, can't oxygenate scenario, which is the cricothyroid view, whereby from here on, we can visualize the cricothyroid membrane for e-fauna. Imagine this, at 2 a.m. in the morning, your junior doctors are going to induce a patient a post-tonsillectomy bleed. Intubation attempt, multiple attempts, and then now you are attempting. Fail, bloody secretion, the oral cavity of full of blood, and then suddenly saturation kept on dropping. You know all this, you know the sound that's made, and then patient turn blue, and then somebody shout, "Can anybody identify the cricothyroid membrane?" Actually, that is already too late because that identification should be done way earlier, even you induce the patient. So if you are lucky, if your patient have a thin neck, whereby identification by palpation of cricothyroid membrane is easy. However, if your patient have thick neck, or for example, in patient had an bleeding in the soft tissue of the neck, identification of palpation of the upper airway is really difficult. However, with the help of ultrasound, this thing can be easy. We know that the first pass success rate of cricothyroidotomy by anesthetist is low as 36%. A major reason for this is because most of us fail to identify the cricothyroid membrane correctly. Thankfully, with the help of ultrasound, it can be this one can be improved up to 5 times. So it will be useful in those who have distorted anatomy, obese patient, or patient who have neck masses. So in order to identify this view, there are two methods. The first one is the TACA method, or in transverse orientation, or another method is the string of pearls, whereby it involves a sagittal view. We'll go to number one first. So the first technique is the TACA method. TACA basically means the first one is T, thyroid cartilage, A is airline, C is the cricothyroid membrane, and A is airline. So basically, this is the sono anatomy that you will get when you use a linear ultrasound in transverse orientation. So you need to appreciate these changes of sono anatomic view. So when you put your probe on the thyroid cartilage, you will get this hyperechoic inverted V structure, which is the thyroid cartilage. And then you slide the ultrasound lower, you will get the airline. So what is an airline? Airline, or in other words, is an air membrane interface happen because of all the ultrasound which have been reflected upwards, because in your airway is air unable to emit ultrasound wave. So it will give the structure of that bright hyperechoic structure like in the diagram. And then when you slide your ultrasound probe even lower, that bright hyperechoic airline will be disappear, and then you will get the cricothyroid membrane, in which in your ultrasound it will look like an inverted U-shaped hypoechoic. And then if you go down even lower, this picture will disappear, and then a second airline will pop up again on your ultrasound view. Alternatively, you can use the second method, which is the pearls of string. Sorry, string of pearls. So basically, why it called so, because your cricot cartilage and your thyroid cartilage appears like hypoechoic beads, similar like pearls. And then if you can see that there's a bright hyperechoic line appears like a string, hence the name, string of pearls. So how are you going to differentiate between tracheal ring and cricothyroid membrane? Is that your cricothyroid cartilage appears the largest out of all of them. So that will be your landmark, cartilage. So just above, just cephalic to the cartilage is your thyroid cartilage. So in between this structure is your cricothyroid membrane. So to help you to make a marking on the patient's skin, what I could suggest is take a blunt needle. The moment you get the cricothyroid membrane, center the view of your ultrasound, and then slide a blunt needle beneath the ultrasound probe at the midpoint. So if you can see here, if you can see that the blunt needle is shown as a hypoechoic line, which is the red color over there. So that will be your reference point. So make a line over the blood needle. So that is your cricothyroid membrane. But when you do this, it is important that you do the marking in the neck position where you're going to do front of neck access. For example, if you do this position in extended neck position, make sure that when you're going to attempt front of neck access in the same position, because if there's difference in neck position, the cricothyroid membrane location can differ slightly. So last, we explore the suprasternal view, which could aid us in endotracheal ETT confirmation. We know that capnography remains the gold standard in confirmation of correct ETT placement, but we also know that all gold standard has its own limitation. And capnography, for example, if your patient have a low cardiac output, low blood pressure, or in cardiac arrest, it is pretty much not so reliable. However, with the help of the ultrasound, you can help us in confirming correct ETT placement. We know that it has really high sensitivity and specificity up to 100% in, especially in pediatric patients. So to do this, you place ultrasound probe, a linear ultrasound probe just above the suprasternal notch, and we get this structure. So in a correctly positioned endotracheal tube, we will get a single airline structure with a single comet tail sign, so you know you are in the correct place. For some reason, if you had accidental esophageal intubation, that one structure will become two. So you get two mucosal interface appearances, and then you get a characteristic of double track sign with two comet tail signs. So you know that you are in the wrong place. So in summary, I'd like to end my talk by four simple messages. Number one is see beyond the surface. Ultrasound provide anatomical information that complements our current physical airway assessment. Number two, think of death with a structured ultrasound examination. It's easy to teach, easy to produce, and easy to learn. Number three is practice makes proficiency. Airway ultrasound, like any other anesthetic skills, it requires repetition, as repetition makes us perfect. Number four, treat our patient and not the ultrasound. Ultrasound is merely an adjunct, is merely a device to help us to do our job, but still clinical judgment still remains the paramount. And I'll end my talk today with this sentence: you can't manage what you can see. And here's all my references. With that, thank you.
Okay, we'll proceed next to the Q&A session. I will invite both speakers to be on stage. And if anyone on the floor have any questions, you can proceed to the mic. Or if you are feeling a bit shy, you can just give your type out your questions from the Slido QR code there. Okay. So anyone from the floor that want to start the ball rolling? Okay, if not, I will proceed from one of the question from the online session. I think this will be addressed to Dr. Ted. What are your views on VAFI, video assisted fiber optic intubation?
Um, uh, my thoughts are anything that's combining or improving the ability to intubate is a good thing. So what we teach is not only standard intubations and video laryngoscope intubations, but combining techniques. So you can always combine, the best would probably be video laryngoscopy and either flexible bronchoscopy, or even intubating through video laryngoscopy plus an optical stylet. And third would be a combination of a supraglottic device and intubating through the. You should always use a bronchoscope to intubate through a supraglottic device. You should not ever use a blind technique. So for the first part, what happens is the video laryngoscope can create the channel and create the view up until the epiglottis. Then the flexible scope can negotiate the difficulty around the epiglottis and down to the glottic opening. If you're combining video laryngoscopy and an optical stylet, again, the problem usually with an optical stylet may be that the epiglottis is not out of your way. And the video laryngoscope can get the epiglottis out of your way to improve the ability of you to get a rigid optical stylet to the airway. And then finally, the supraglottic device gets you the channel, gets you down to the, hopefully to the glottic opening, and then the fiber optic scope will help go past the vocal cords and allow you to have a smooth intubation with the railroad in the endotracheal tube.
So I've actually have used Wafi before. The only thing I think is you'll need a two anesthetists to do it. So if let's say it occurs in the middle of the night and you're alone, that might not be very feasible actually.
Sure. That would be the video laryngoscopy and the flexible scope.
Yes.
You can actually do combined video laryngoscopy and optical stylet by yourself with your, to be honest, you can do
Because
it by
it's a
yourself,
single
but your assistant may just have to push the tube off at the most. Again, and then the video assisted supraglottic intubation also can be done by yourself. You put the video you put the supraglottic device in, and then you can put the fiber optic scope and the endotracheal tube in place. So technically speaking, only the video laryngoscope and the flexible scope do you need actually two people.
For any question from the floor? Okay, I will proceed with another question. This is for Dr. Shafiq. When do you apply ultrasound to predict difficult airway versus the traditional assessment, and how does it change your airway plans?
Okay, honestly, not many, because nowadays we have video laryngoscope. So with video laryngoscope alone, you can get away with a difficult airway. So very, very rarely I practice, frankly speaking, perform airway ultrasound. The only times I will try to attempt in cases whereby patient have very thick tissue, for example, bleeding, not bleeding inside, bleeding in the soft tissue. We had cases, it's a motor vehicle accident, he had a high cervical fracture, and then there's a bleeding in the soft tissue, so it's really big hematomas there, and then we are about to induce this patient, ENT unable to even palpate the tracheal rings, let alone if you want to palpate the cricoid cartilage. So nobody's know where to do. So from the CT scan was done, there was a huge hematoma and neck has been pushed to one side of the. So in that place, we did an ultrasound of the patient and we hope to locate the, basically, it's not much of the identification of the cricothyroid membrane. It's just that you can know where is the midline and how deep is the structure is. And with that information, it helped our ENT clinic really help a lot. So thankfully, this patient managed to be awake. Tracheostomy has been done, but with the identification of the midline and where is the location of the tracheal rings, ENT managed to perform the surgery really well. So I think, yes, I think really selected cases, yeah, because of the advancement of a video laryngoscope.
So actually, this brings back to the topic where I actually has a question for both of you. So Dr. Shafiq demonstrated the powerful point of care ultrasound for predicting difficult airways. And from for Dr. Ted, from your airway stewardship perspective, so how do we actually systematically integrate sonography into standard hospital pre-op protocols rather than leaving it as an optional skills? Is there a way to, like, even when it's not routinely done, is there any way that we can actually combine it in the pre-op settings?
Um, okay, so basically the ultrasound, the vast majority of the time should be done preoperatively. You need the assessment because it takes time. And if you're doing it in an emergency situation, it doesn't help, or it's sometimes too late. And it takes time instead of doing the action of trying to secure the airway. So yes,
after the um, post-tonsillectomy bleed, we all know uh, the case. What I do is I try to make a mark on the patient's neck, identify the cricothyroid membrane. That's the least thing that I would do, because I'm not sure about you. I had quite difficulty in identifying a correct placement of the cricothyroid membrane. So I will only do in patient whereby I anticipate that a possibility I may not be able to secure this airway despite using fiber optic intubation or a weight tracker intubation or any sort of methods. So I will try to at least make a marking on the skin to know that's the cricothyroid membrane. But again, like Dr. Wong said, in emergency situation, it's pretty much difficult. Yeah, you need to prepare beforehand. So there's a limited role of ultrasound in this case.
So any questions from the floor? Okay, if not, I have another question. Actually, this is for Dr. Wong, sorry, Dr. Ted. So with the rapid evolution of airway technology, how does the airway group decide with when an existing device or the airway card is truly obsolete or needs to be replaced countrywide versus just being a passing trend? We have budget constraints. We have so many new inventions. Actually, which one to choose? Which one actually is something to stay and keep?
most of it is by trial and error, right? So, I mean, I know there is a push from D- DL to universal VL, but you know, from a practical and financial point of view, I mean, there are some countries that cannot afford uh, having VL everywhere and using that as the standalone. Um, so I still believe that we should teach direct laryngoscopy um, and uh, having video laryngoscopy as a first alone, only if you are financially ability to finance it everywhere you go. Because if you just have video laryngoscopy and you end up going to a hospital that doesn't have video laryngoscopy, then that could be problematic. Second of all, there is also a newer push that there are some anesthetists in the difficult airway society that are now pushing for hyperangulated blades as first choice. So you're shifting even more, and the hyperacute angulated blades are even more expensive. So you have time constraints are basically trial and error. Same, I mean, as I pointed out, there's a huge explosion of, okay, let's talk about super large devices. There's so many of them. So we decided we would narrow it down to two choices. One is the ProSeal, which is reusable, and it's malleable. And then the disposable